Well, thank you. Welcome. I appreciate the opportunity to be here speaking live with you. I wasn't sure yesterday if that was going to happen, so I was happy that my flight ended up taking off. And I'm excited to be here and honored to present to you about the evolving pathophysiology of migraine. We've really come a long way, especially in the past couple of decades, and I'm excited to be a part of educating in that, but also excited to be a part of presenting these medications to our patients and utilizing them in clinical practice. These are a list of my disclosures. I won't be presenting any off-label medications, but I will be discussing some medications that are currently in development. And these are the key takeaways that I hope you take, that we demonstrate an understanding of the evolving migraine pathophysiology, identifying patients who should be offered preventive therapy for migraine, recognizing both the acute and preventive therapies currently available that target the Cgrp pathway, and understand some of those limitations of Cgrp antagonists. So why does this matter and why should you care? Well, it turns out that migraine is the #1 reason for referral to a neurologist. So whether you go into dementia or stroke or neuromuscular disease, you are going to come across people living with migraine, and chances are that you are going to be managing migraine disease in addition to whatever else they're presenting with. Migraine is incredibly common. In fact, nearly 12% of the US population is afflicted with migraine. That's more common than asthma, epilepsy, and type 1 diabetes combined. Nearly 38 million Americans living with migraine. Additionally, migraine is high in disease morbidity. In fact, it ranks second, according to the World Health Organization, in years lived with disability. When you consider the time that migraine peaks in someone's life between the ages of 15 and 55, these are important, busy times in our lives. We're graduating, starting new career fields, starting families, and having a disease that really takes us out of these engagements is tremendously impactful and something that we really need to recognize and advocate for our patients. But what we know is that effective preventive therapies can actually reduce migraine frequency, can help restore functioning, and reduce risk of progression to a more serious form of this disease. I want you to know that we are underutilizing migraine preventive therapies. In fact, of the estimated 40% of people with migraine who should be offered a preventive treatment, only about 12% are actually receiving it. So when should we start preventive therapy? I'd like you to consider the number 4. At 4 monthly migraine days of at least moderate intensity is when the American Headache Society says we should start this. I'll tell you that back in Oklahoma, this is not the number I'm seeing when preventive therapy is begun. In fact, I see it's closer to 8 to 10 migraine days per month. And that carries a high risk of progression into chronic migraine, which is a more severe and disabling form of this disease. So we really need to be containing this disease state earlier, considering preventive therapy early in the course, so we're not seeing that central and peripheral sensitization of the trigeminal system. And as we've seen, diagnosis is that most important step, but the truth is that nearly 50% of people with migraine go misdiagnosed or underdiagnosed. And this is not just limited to people outside of neurology. I can't tell you the number of patients I see in my practice that have been to see neurologists who should be experts in the field of migraine and headache that are still receiving misdiagnoses. So what do we use to help guide our diagnosis of headache? This is the International Classification of Headache Disorders. We're on the 3rd edition since 2018. And what you can see is that we group these into Part 1, which are primary headache disorders, no identifiable cause. Part 2, which is our etiology-based disorder, something that we can actually point to and say this is the identifiable cause for the headache. And Part 3 include our facial pains, our neuralgia pains, and other more specific headache diagnoses. We also have an appendix of various disease states that are garnering attention or maybe proposed to be included in future classifications. So I want to briefly just take a look at the diagnosis of migraine. And what I want to point out is that when it comes to the clinical characteristics of migraine, you don't have to have all of these to be present. So I've heard for a long time that migraine must be unilateral and it must be a throbbing, pulsating pain. But the truth is that about 60% of migraine is unilateral, about 60% is throbbing or pulsating. So that leaves another 40% that don't have those characteristics. So remember, 4 clinical characteristics. Is the pain one-sided? Is it throbbing or pulsating? Is it of at least moderate intensity? And would you prefer to avoid physical activity? Any 2 of those are present, and we would move into the associated symptoms. So a common complaint I hear, bifrontal, bioccipital, pressure type pain with neck pain. That's a tension type headache, right? Not necessarily. So let's go through our clinical criteria. I said that the pain was bilateral, so I don't get a point for unilateral. I just mentioned that it's pressure-like, so I don't get throbbing or pulsating. But if that pain were of at least moderate intensity, and let's say I'm avoiding my afternoon run, or maybe I'm not doing the laundry because I just don't want to be moving around, or I'd rather be lying in bed, I've met the clinical criteria and I would move into associated symptoms. When it comes to associated symptoms, we don't have to have all of these present to make a migraine diagnosis. And I also can't overemphasize that associated symptoms are not a severity scale. So this doesn't have to be in bed, vomiting, lights out, sounds off. Although that is a migraine attack, that's severe. But we can have mild sensory phobias and still qualify as migraine. So nausea with or without vomiting, or light and sound sensitivity. How many of you have patients that say, lights don't bother me with a headache, and they're sitting in the exam room with sunglasses on? And I say, I notice that you have sunglasses on right now inside as we're talking. And they'll point to the lights and they'll say, well, those lights irritate me, or the computer screen irritates me, or scrolling on my cell phone irritates the head pain that I have. So remember that this is also not an all or nothing phenomenon. That is photosensitivity, even if it's very specific photosensitivities. And we have to recognize those because they suggest meningeal irritation. So I, for one, am very thankful that I was not suffering from migraine back in ancient times. In fact, it turns out that one of our earliest treatments of migraine was actually trepanation, a form of drilling a hole into the skull to release pressure. And I've had patients that say, if you could just drill a hole, it's going to help me. But we've also seen that as soon as 1200 BC, actually an Egyptian papyrus was written terms like neuralgia, migraine, and they would actually take a clay crocodile with holding a grain in its mouth, holding it to the head of someone to help fix their migraine pain. Hippocrates in 400 BC, the father of medicine, was the first to really describe the visual symptoms of migraine. So he describes this shining light, usually one-sided in the right eye for him, followed by a violent pain in the temples, and eventually it would spread to the entire head into the neck region, and we'll talk about some of that pathophysiology as well. And then we see in 100 AD, first time to call this hemicrania. Many of us are very familiar with the vascular theory of migraine. In fact, this was one of the most widely accepted theories of migraine that we had. And this was coined by Wolff. And what we saw was that aura was caused by vasoconstriction, with that pain contributed to or attributed to the reactive vasodilation that took place. But we've had a number of errors with this, and that only about 24 to 33% of people with migraine actually have aura. It also doesn't explain the premonitory symptoms that we see before aura or head pain ever take place. Some of our medications used to treat migraine don't affect blood vessels at all. And then our blood flow studies are suggesting that vasodilation is an epiphenomenon of the attack, not the cause of pain itself. So our conclusion has been that dilation of the vessels is neither necessary nor sufficient for causing migraine pain. And you can see this here during one of our MRA studies during a spontaneous migraine attack. What we saw in this study is that there was no extracranial arterial dilation. There was mild dilation of intracranial arteries, and then sumatriptan reduced headache without constricting the intracranial arteries at all. Furthermore, we know that the throb rate of migraine does not correlate with arterial pulse. And so thus the changing concepts of migraine were born, and now what we accept as the Trigeminovascular theory of migraine. So we believe that migraine is primarily a disease of brain hyperexcitability, and although vasodilation may occur as part of this disorder, it's not required for migraine pain. I mentioned already that migraine therapies, several of them do not work by constricting blood vessels. And so in conclusion, migraine is an inherited complex brain disorder. It is not a vascular headache. So since the microarray of the vessel wall, we actually have been able to see a lot of these molecular mediators, and these have garnered a lot of attention as potential therapeutic targets for stopping a migraine attack. And what I want you to know is, although we think of the headache as the primary feature of migraine, migraine actually has 4 separate phases, including premonitory, aura, headache, and the poststrum. There are also patients that actually experience interictal symptoms, and I'll take you through some of these individual studies looking at PET studies and different areas of the brain that are involved. So here we can see the prodromal phase, and in the prodrome, this could be a few hours up to 48 hours before the migraine attack ever begins. Symptoms that we hear described include things like mood changes, irritability, sometimes euphoria. Neck pain can actually be preceding the headache phase of a migraine. We can see food cravings or food aversion, some patients experiencing nausea even before the migraine pain ever begins. And premonitory symptoms are estimated in about 80% of patients with migraine. What our PET studies show us are the activation of the hypothalamus, the periaqueductal gray, and the dorsolateral pons. What about nausea? Nausea is interesting because more than 50% of patients do report nausea with their migraine attack, but 25% of them actually report it before the migraine head pain ever begins. And what we see again in our PET studies are these areas that are very implicated in circuits mediating nausea. So again, periaqueductal gray and the rostral dorsal medulla and the various structures that are involved there. Aura is interesting, and we actually know a lot about what happens during aura, but some of the controversy is that how the aura connects to pain. And initially it was believed that aura actually triggered or began the pain of a migraine, but there have been some controversies with this, again, in that it doesn't explain the premonitory symptoms that happen before the aura ever starts. And so that we know that aura is typically between 5 to 60 minutes. We see these visual descriptions, as I mentioned, Hippocrates first describing, but also sensory symptoms, and a smaller percentage of patients, motor symptoms, even vertigo, dysarthria, or ataxia. And so what we see and what we know that happens during aura is we have this wave of intense cortical neuronal activity, and it's followed by this wave of cortical depression. And these are believed to be increased regional cerebral blood flow followed by that decrease in cerebral blood flow. And we know that local oxygen supply is still sufficient, so it's really oligemia, not ischemia, that takes place. This propagation happens at about 2 to 4 millimeters per minute, and this correlates with the aura symptoms that we see. But again, the vasodilation theory of migraine doesn't really hold true because we see this occur across vascular territories. And so difficult to describe that if it was simply just vasoconstriction taking place. So what about the headache? What's interesting is that we're really not sure about the triggering event. We don't have necessarily that direct correlation of what begins it all. We know a lot about what takes place in the Trigeminovascular system, and so I'll walk you through what we know about the pathophysiology of the headache phase. You can see here the meningeal arteries are the afferents of the trigeminal nerve, and so these are the thinly myelinated, unmyelinated fibers, and they innervate the vasculature, but also other pain-sensing structures like bone, sinuses, and skin. From those afferents, from the trigeminal ganglion, there are projections into the brain stem, and the trigeminal nucleus actually converges with the upper cervical sensory ganglion in an area of the pons referred to as the trigeminocervical complex. This is the reason we actually see about 75% of people with migraine experience the associated neck pain with migraine. From the trigeminal nucleus, second-order projections up to the hypothalamus, the thalamus, and then we have our thalamocortical projections where actually pain is perceived as pain in the cortex. And so some of the controversy surrounding this has been, do we need activation of the sensory afferents in the periphery, or is it abnormal perception centrally of the afferents that are taking place at a central level? And what about the prostrum? This is actually what we know the least about. Research is actually limited, but if we knew how a migraine attack stopped, that could be a potential therapeutic target. We know that about 80% of people describe poststrum, and I hear patients in my practice say, I feel like I've been run over by a truck. I've run a marathon without training. I get that hangover sensation. And there's this thought that there perhaps is a global reduction in cerebral blood flow. EEG and visual processing studies have suggested this abnormal excitatory and inhibitory disequilibrium. And then, as I mentioned earlier, we do have some patients that experience symptoms even between attacks. And so these are things like heightened pain sensitivity, heightened light sensitivity, smell sensitivity. And it's believed that this may be related to a lack of habituation or cortical hyperexcitability. So you can see this complex interplay in the numerous symptoms that are experienced in just one migraine attack related to the various brain structures that have been implicated. And I mentioned earlier that with seeing the vessel wall pathology, we really have garnered attention into many of these molecular mediators as therapeutic targets. So you're familiar with our serotonin agonists. Reminder that triptans were first FDA approved in the early 90s. These are predominantly agonizing 5-HT1B and 1D receptors. The 1B receptors responsible for the vasoconstrictive effect of triptans. To a lesser degree, some agonist activity of certain triptans at the 1F receptor, but of course our newest class of serotonin agonists, the ditans, first FDA approved in 2019, commercially available in 2020, are predominantly agonizing the 5-HT1F receptors. I'll delve into more details specifically pertaining to Cgrp and PACAP, but a reminder that we do have other neurochemical systems at play in migraine. So calcitonin gene-related peptide has garnered a lot of interest, especially since the release of the monoclonal antibodies in 2018. Cgrp exists in both an alpha and beta form, with the alpha form more prominent in the central nervous system. And you can see here that the receptor is a heterodimer. It's a combination of the calcitonin receptor-like receptor and the RAMP1. These two couple with two cytoplastic proteins that actually lead to stimulation of adenylate cyclase. Where exactly is Cgrp located? It is primarily within the C and A delta sensory fibers of the dorsal root and trigeminal ganglion, also within varicosities along the axons of the C fibers, and it can be released either at the periphery or from central terminals. It is a potent vasodilator, and so a reminder that when we are using Cgrp antagonists, we prevent a dilation process, but there's no active vasoconstriction that takes place. And what we know is that both Cgrp and its receptor are localized throughout many portions of the trigeminovascular pathway that are particularly important in migraine pathophysiology. We've learned a lot about Cgrp and headache over the past 2 decades. We know that it's elevated in the plasma from the external jugular vein in acute attacks of both migraine, cluster headache, also paroxysmal hemicrania. We know that successful abortion of a headache with sumatriptan is accompanied by reduced levels of Cgrp. We also know about the timeline of CGRP, that it's highest in young adults between the ages of 20 to 40, and it declines with age in a similar pattern to what is seen in migraine epidemiology. And we know that by exogenously administering CGRP, we can actually provoke a migraine attack, and by blocking CGRP, we can prevent it. And I mentioned before, it is a potent vasodilator. CGRP's effect on nociception has also garnered quite a bit of attention, both in its peripheral and central sensitization modulatory effect. And most of the evidence suggests that it is modulatory effect of CGRP rather than a direct nociceptive effect. And we can see promotion of peripheral sensitization through the release of inducing sodium channel conductance, also promoting the release of nitric oxide from those primary afferents. CGRP's ability to promote central sensitization has already been established as well, both in the spinal and supraspinal mechanisms. It's believed that these supraspinal mechanisms and the involvement in the trigeminal nucleus caudalis, the periaqueductal gray, and lastly the central nucleus of the amygdala are where these are likely relevant. I want you to remember the difference between a neurotransmitter and a neuropeptide, and that a neuropeptide is not confined to the nervous system. So remember that CGRP is found throughout the body, and it does modulate a variety of functioning. So let's talk about the two classes of Cgrp antagonists that we now have available for migraine treatment. You're likely familiar with these. First are the monoclonal antibodies. These are large molecule antibodies that can block Cgrp in one of two ways. One is by binding to the receptor site of Cgrp, or by binding to the Cgrp ligand itself. All four of these that have been developed are for the preventive treatment of either episodic or chronic migraine. And then we have our GPANTs, which are our newest class of Cgrp antagonists. These are indicated for both acute and preventive treatment, and they are all blocking the Cgrp receptor. You can see listed here the four FDA-approved treatments for the preventive treatment of migraine. 3 of these are self-injectable medications. One of them is an IV infusion. They differ based on, again, that target, whether we're targeting the ligand molecule CGRP itself or the CGRP receptor site. They vary in terms of the IgG subclass as well as the half-life, and you can see that there are various dosing regimens for each, with the self-injectables being available either once monthly or once quarterly, and the infusion being available once quarterly. I think probably one of the biggest advantages of our monoclonals has been their tolerability, right? So we know across this group, we see hypersensitivity, injection site reactions as possible side effects. We also know about the possibility of our receptor blocker for causing constipation or high blood pressure, and our infusible has been associated with nasopharyngitis. I want to point out that this is not meant to be taken as comparison, but rather I want you to see the general trends in the clinical studies. There are no head-to-head comparison studies of these, and drawing conclusions of this as a head-to-head comparison would be wrong, given that each of these clinical study designs is set up very differently in terms of patient population, migraine severity, frequency, how we defined various terms. So what I want you to take away from here is that in our episodic migraine trials, we're seeing anywhere from 40 to 60%, 50% response rates as far as migraine reduction. And same story with our chronic migraine population. For comparison across the group, 50% response rates, about 37%. So some caveats or clinical pearls. Long-term safety is relatively unknown. Now, I will point out that we do have safety data exceeding 5 years, which is very important, and we have gotten a lot more clinical exposure to these medications. But we do know that CGRP could potentially be an important fail-safe mechanism in ischemic emergencies, and what that could translate to, we are really unsure. Studies also exclude these complex refractory patients. We also do not know about the effect during pregnancy. Now, most of these companies do have pregnancy registries available, and I encourage you to please enroll patients who potentially became pregnant while on these medications. But reminder, long half-life, taking about 5 months to clear from the system, and it is recommended to use effective birth control method and discontinue at least 6 months before conception. Cost could be an issue, but most of these companies for commercial access patients are going to have these copay programs that make them available. So who should we consider prescribing a monoclonal antibody? The American Headache Society says a failure of at least 2 oral preventive therapies, and that's either a lack of response, inadequate response, or intolerance. The medication helped, but I was having too many side effects to it, or in a patient that has comorbidities and contraindications to other existing therapies. Again, only listed contraindication is hypersensitivity reaction. And fortunately, we do not have drug-drug interaction. So I think that this is very beneficial in patients who may be on polypharmacy, keeping that in mind. I will also point out that the Mayo Clinic put out a great review assessing monoclonal antibodies and vaccine status, and it is not recommended to discontinue or hold these medications regardless of when someone may be receiving a COVID vaccine or booster. And then I've already mentioned about insurance coverage. So let's shift gears into our newest class of Cgrp antagonists. Again, these are the gPANTs. They are small molecule Cgrp receptor antagonists. gPANTs were actually studied initially in the early 2000s, but we had difficulty with oral bioavailability and also hepatotoxicity. And so currently our new FDA-approved gPANTs, ubrogepant, rimegepant, and atogepant are available. What's unique and differentiates this class is that for the first time in history, we've actually seen a dual mechanism treatment available. So you'll see that ubrogepant is indicated for the acute treatment of migraine, but rimegepant has both acute and preventive indication, and then atogepant has preventive indication. So this is exciting because it's the first time in history that we've seen this on-label treatment with dual potential. Again, pointing out this is not meant for head-to-head comparison, very different study designs, but what I want you to see is that across the gPANT acute clinical trials, about 20% of patients are completely migraine pain-free, close to 60% of patients are achieving pain relief. We're also seeing that gPANTs can affect the associated symptoms of migraine, nausea, light, or sound sensitivity, and then these medications have very sustained pain freedom as well. This is also looking at their indication for episodic migraine prevention. And what we're seeing for the monthly migraine reduction is about 4 days reduced per month on average. We're seeing about 50% of patients having at least a 50% reduction in migraine days across those 12-week treatment cycles. And I think what's really encouraging about this class is that they could work as soon as the first week after dosing. So part of our history in migraine has been telling a patient we're going to start a medication, titrate it over several weeks, and then it may be 2 to 6 months before we start to see that preventive effect. With gPANTs, we're actually seeing this potential as soon as the first week after taking them. Side effects, all less than 10%, fatigue, somnolence, nausea, abdominal pain, dyspepsia, constipation, and decreased appetite are listed. Fortunately, our 52-week safety trials did not identify any safety tolerability findings that were new, and the majority of the side effects in these clinical trials were mild to moderate. But we do need more long-term safety with the gPANT class of medication. We also, as far as mixing multiple gPANTs together, we need more safety studies and efficacy studies to tell us about this. It's very encouraging that these medications do not have that potential for medication overuse headache as our prior triptans did. So a reminder, triptans used more than 9 days per month can contribute to medication overuse headache. So I'm hopeful that gone are the days of telling patients, we want you to treat early in a migraine attack, but wait, don't treat too often. With these medications, we don't have that potential. We also don't have the same cardiovascular contraindications as our triptans, but reminder that CGRP may be an important fail-safe mechanism in ischemic emergencies, and cost could be an issue down the line, but currently for your commercially insured patients, they're covered, which is exciting. So I'm going to shift gears into our newest focus, which is Pituitary Adenylate Cyclase Activating Peptide, or PACAP, as I will heretofore refer to it as. PACAP was first discovered in 1989 when it was isolated from ovine hypothalamus extract, and it was shown to stimulate this adenylate cyclase production as well. It actually belongs to the same superfamily as the structurally related vasoactive intestinal peptide, or VIP, and that family includes secretin and glucagon. What's unique about PACAP is that it's actually been described in a number of different ways. It modulates a variety of functioning, and we're going to talk about that both within the central nervous system as well as throughout the body. But it is widely distributed. It's involved in neuroprotection, neurodevelopment, nociception, and even inflammation. And what we found with our human studies is that it is a potent inducer of migraine-like attacks, but the full mechanism behind this has not been elucidated. PACAP is found in two bioactive forms, a 38 amino acid containing peptide called PACAP 38 and a 27 amino acid containing peptide called PACAP 27. PACAP 38 is actually responsible for about 90% of what is found throughout the body. And we know that both of these neuropeptides can stimulate or activate the three PACAP receptors. So you can see we have VPAC1, VPAC2, and PAC1 receptor. But what's different about VIP versus PACAP is that PACAP has 100-fold higher selectivity for the PAC1 receptor. And you can see two of the molecules, two of the antibodies that have been in development, the first being AMG 301, which I'll discuss in more detail, but this was an antibody binding to the PAC1 receptor, and then ALD 1910, which is an antibody binding to PACAP itself, excuse me. So PACAP distribution, I mentioned before, PACAP is widely distributed, and a lot of its attention really did circulate around its inclusion in various structures that have high migraine implication. And so of special interest to migraine, PACAP is located in the paraventricular nucleus of the hypothalamus, the ventrolateral periaqueductal gray, locus coeruleus, the solitarius nucleus, the trigeminal nucleus caudalis, and the trigeminal ganglion. And remember, these are all structures highly implicated in migraine. When we look at the receptor sites, VPAC1 and 2 versus PAC1, the receptors are a bit different. So you can see that VPAC1 and 2 are located in the cranial arteries, with VPAC2 also in the hypothalamus and trigeminal ganglion, but PAC1 is a little different. It's actually located really throughout. You can see the thalamus, even the cerebellum, pontine nuclei, trigeminal ganglion, but it's not located in the cranial arteries. In the central nervous system, PACAP has actually been described as a neurohormone, a neuromodulator, an immunomodulator, and this largely is related to the various physiologic conditions that it has implication in. So you can see, we see sleep-wake cycle, we can see cognitive functioning, we can see emotions, we see stress, anxiety has been implicated with PACAP models. And PACAP and PAC1 receptors have been implicated in pathophysiologic conditions as well, both in inflammatory processes as well as in pain processes. So in the headache world, it involvement in migraine as well as cluster headache, but in inflammatory conditions such as arthritis models, anxiety, and potentially PTSD. The Danish have published several studies of PACAP in human models, and what you'll see here is looking at both PACAP 38 and PACAP 27. These studies were randomized, double-blind, placebo-controlled crossover studies. So PACAP 38 on the left-hand side of your screen, you can see 12 healthy subjects and 12 subjects with migraine were recruited, and they would come to the lab at various intervals, and it would be randomized as to whether they would receive PACAP infusion versus placebo. And what we see is that nearly everyone experienced headache with PACAP infusion, 92%, 25% experiencing headache with placebo. But when it comes to migraine, it's a bit different. Over 50% of patients with migraine features, none of them with placebo. And similar studies were shown with PACAP 27. Again, 90% of individuals with headache versus 30% on placebo, and 55% of those being migraine with only 10% placebo. There were also MRA studies done to show the role of PACAP versus VIP in vasodilation processes. So you can see here, they studied the superficial temporal artery, which is an extracranial artery, the middle meningeal artery, and this was also an extracranial segment, and the middle cerebral artery, obviously an intracranial segment. And what you can see is that PACAP versus VIP, neither of them changed the circumference of the intracerebral vasculature. But when it comes to the extracerebral vessels, the MMA and STA, we can see that rapid vasodilation, but then that's sustained with PACAP. And I'm told that you can even see this clinically, that whereas VIP will induce this flushing and vasodilation very quickly, it's quite short-lived, as opposed to PACAP, you can physically see flushing for up to 24 hours after infusing it. In this study, 8 out of 9 reported an immediate headache, 100% reported delayed headache after PACAP infusion. And then again, we have this sustained dilation of the extracranial arteries. Here's a head-to-head comparison of PACAP and VIP, really showing that we do believe that that prolonged vasodilation that we see with PACAP is likely the pathophysiologic mechanism and in its involvement in migraine. You can see with PACAP and VIP infusion that headache was quite likely, 91 and 82%. However, when applied with migraine features, 73% induced by PACAP versus only 18% in VIP. So we believe that it's not just vasodilation, but actually the prolonged extracranial vasodilation as potentially that migraine-inducing mechanism. So our key takeaway points, both PAC 27 and PACAP 38 infusion did induce more migraine than VIP. Plasma levels of PACAP have been shown to be elevated in both the jugular cubital blood vessels and decreases as headache ameliorates. PACAP induces this marked extracerebral but not intracerebral dilation of arteries. And then I didn't show this study, but actually we know that PACAP 38 induced vasodilation is blocked by sumatriptan. And so thus PACAP could be a potential target for pharmacologic migraine treatment. So this was the first study that we saw regarding PACAP and PAC1. AMG 301 is an antibody that was targeting the PAC1 receptor site. Unfortunately, although safety and side effects were good, we did not meet the primary endpoint. So we can see various doses of AMG 301 versus placebo did not outperform placebo in regards to mean monthly migraine day reduction. So the newest trial that is currently there, estimated completion date just last month, well, we're in February, 2 months, December of last year, is ALD 1910. And this is actually targeting PACAP itself, so the ligand. One of the questions that arose from our previous study was, are we targeting the right receptor? I remember I showed you earlier VIP1 and 2 receptors located on arterial sites, trigeminal ganglion, but PAC1 not in the cranial vasculature. So wondering, is that really the right receptor site that we should be targeting pharmacologically? But this is targeting PACAP 38 itself. And what we're looking at is actually PACAP 38's results on both vasodilation, heart rate increase, as well as headache. And I tried to get some early data on this and unfortunately was not successful in that. So The questions have arose because PACAP does have so many numerous physiologic conditions implicated. What could the potential side effects be? And we know from our antibodies, it's unlikely that they would cross the blood-brain barrier. And so most of the side effects potentially have been risen in regards to peripheral blockade. And questions as to potential dysregulation of the pituitary gland, alterations of immune or inflammatory processes. We know that PACAP deficient mouse models have shown more significant disease. Potential alteration to metabolic stress as well. And then mentioning again that vasodilatory response through the CAMP production. So in summary, migraine is an inherited complex brain disorder. And while vasodilation may occur as part of this disorder, it's neither required nor sufficient to explain all of migraine pain. We know that Cgrp antagonism has provided a reliable target for both acute and preventive treatment of migraine, and it is a well-tolerated safety profile. PACAP and PAC1 blockade are promising, but of course results from clinical trials are needed to confirm both efficacy but also potential side effects seen. I appreciate your time.
I'm very impressed that the first time PACAP is mentioned in slides in my life.
Oh.
I'm working 7 years on PACAP role and VAP together in neurology. In the literature, they have in 13 symposiums international on VAP and PACAP. The last was in LA. You're the first American. They are all French, Chinese, involved in this super interesting hormone PACAP. But I think that PACAP in the half-life is only in 5 minutes. And VAP and PACAP, they have action together. That's why they need to be together. That's why maybe it's the failure of PACAP antibodies, because VAP is not blocked. And 78% they have similar function. That's why maybe the future in VAP and PACAP need to be seen together for the migraine and other diseases. But I'm very, very impressed.
Appreciate the comments, yes. And I think that calls to question which receptor sites that we're blocking, because of course, VIP and PACAP can target both the VPAC1 and 2 receptors, but VIP is not targeting the PAC1 receptor. But I think what's interesting, and right, VIP has a much shorter half-life. I think my reading was about 2 minutes versus 7 to 10 of PACAP. But VIP did not induce migraine as much as headache as PACAP. But maybe you're right, maybe it is more of that receptor pathophysiology, which has been the big controversy.
Thank you. I'm just curious, I feel like right now we are choosing medications for migraine based on side effect profile, whether or not someone wants to do an injection. Are you aware of, or do you see a future for biomarkers that will guide more targeted choice of treatment, and specifically with these newer immunological agents?
Yes. So we actually do have an international registry focused on biomarkers that was headed by Dr. Dodick of Mayo Clinic Scottsdale, and I don't remember the exact number of countries now participating, but that is a big focus. And hopefully one day we may be able to draw blood and decide this is the best medication for you.
First of all, thank you for a great lecture. I learned a lot. I was thinking about the prevalence of migraines in certain populations, and I didn't really hear anything that explained to me about the gender differences between the prevalence of migraines in males and females, and also, other triggers like a PFO or something like that. Is it becoming better understood over time?
So we believe that the gender predilections are likely related to hormonal factors involved. So we see that in boys, they tend to peak during childhood, adolescence, and improving, maybe some in later life, but for women, very clearly during our childbearing age. And it's likely that estrogen withdrawal that is a predominant trigger for migraine. I know that there's a lot of research, especially at UCSF, in regards to PFO, and there has been correlated potentially higher incidence of PFO and migraine with aura. The question has really been that closure of PFO has not necessarily panned out, as I know you're familiar with any sort of treatment or improvement in incidence of migraine with aura.
So do we think that there's a connection, though, between the estrogen or the change in blood flow with the PFO and the amount of the biochemicals that we're now targeting for treatments?
I'm not sure that we know that. I mean, there's a lot of factors that I think are involved, questions relating to potential hypercoagulable states along with PFO present, and could they be potentially what we're seeing migraine with aura happening in that population. But I guess your question is pertaining more to CGRP's role with a PFO, and I'm not sure.
Thanks.
Okay, I'm going to read a few from our virtual. So, what is the strategy you use when you try to take patient off CGRP 6 months before pregnancy when the patient has had a good control with it and had prior refractory headaches?
Yeah, so I think that that's a great transition into our GPANT class of medications. We know the various half-lives of these medications. And so from our preventive side of thing, half-life of 11 hours. So it allows me to transition someone off of a monoclonal and then perhaps, within a week or so of anticipating pregnancy, discontinue a GPANT.
And then what do you use during pregnancy?
So that is the million-dollar question. I use quite a bit of nerve blocks. I have a lot of individual discussion pertaining to the fact that we do not have studies or reliable safety data. I do present to them the animal data that we have on hand in regards to various GPANTs. I also will discuss with them the potential of using a triptan during that second, potentially midway through the third trimester of pregnancy. But this is very challenging. I utilize mostly nerve blocks and neuromodulation.
Great. Why not use the CGRP as a first line rather than having to fail 2 to 3 oral agents, since the side effect profile is much better as well as the efficacy?
Yeah, so I think that as clinicians, we also have to balance, the cost, the socioeconomic cost of migraine management. And we do still see patients that have quite excellent response to our oral preventives. I think that if we could, perhaps reduce cost of some of these medications, going to them first line would be completely appropriate. And I envision at some point that we will.
Great. Is there a role of CGRP treatments in chronic daily tension type headache?
So chronic daily tension is one form of tension that I think may present to the doctor's office. I actually am of the mindset that I think that tension type headache in episodic form likely does not show up. But I would also very much argue that chronic daily tension type headache may be migraine. And so I would certainly try a CGRP antagonist. And I think that if you're seeing clinical efficacy, you've now done a diagnostic and therapeutic trial.
And how long do you trial?
So I recommend at least 3 months on any preventive agent. We initially, when the monoclonals came out, Our first wave of practice, we would start them for a month, and if patients didn't respond, we would discontinue. And then we moved to 3 months, and actually Dr. Silberstein did a study looking at non-responders of the monoclonals. And of those who had not responded at 3 months, he went on to say what percent would respond at 6, 9, and 12 months. And it turns out that there's still a decent amount of responders up into 6 months. And I think for me, the question really comes into the nociceptive effect of CGRP and the sensitization of the nervous system. So my recommendation for the monoclonals is a 6-month trial. Orals, I would say a minimum of 3 months, but even potentially longer when it comes to CGRP suppression.
Great, and I think we have time for one last question from a couple of the virtual attendees. Really, what is the difference between post-traumatic headache versus post-traumatic migraine? Are they the same thing? Is one acquired? Is one not? So how do you classify post-traumatic headache as acquired headache rather than confuse it with migraine?
Right. So post-traumatic headache is a clinical diagnosis where headache happens in relation to trauma. But it's managed according to its clinical phenotype because, of course, we don't have on-label treatment for post-traumatic headache. So rather than post-traumatic migraine, I would still have a diagnosis code of post-traumatic headache, and then I would also be including migraine if you have the clinical phenotype. So is there light, sound sensitivity, and or nausea?
Fantastic. Thank you so much. Any further questions? Great talk. Thank you for coming.
Thanks.
That was great.